Hello everyone, and I hope everybody is doing perfectly fine. So today what I'll be taking is a lecture on tumors and tumor-like conditions which are noted in period of infancy and during childhood days. So there are many tumors which we talk about. Usually we think like that the tumor or malignant conditions that according to the age we see it in middle-aged groups or elderly individual. But in infant and childhood also there are certain tumors which we have to remember that becomes an important differential diagnosis when we study about tumor or certain tumor like conditions in infancy or childhood. So let's start. So when we come to tumors of infancy and childhood, what we see that it comprises 2% of all malignant tumors, and it is a leading cause of death in this age group. Benign tumors are more common, as we all know, with less important consequences, but they also need proper management. What is important? And then it becomes very important to differentiate these benign tumor from the tumor-like lesions and from the tumor proper. So for that, we need to have a thorough evaluation, or you can say thorough microscopic examination of different or various types of tumors. What we have to remember is the histogenesis. What is the basic mechanism which is involved in generation of these tumor during this age group? So this histogenetic evolution of tumors at different age groups, you can say like some are different developmental tumors, like tumors which have evolved in utero and they are apparent at birth or in immediate postnatal period. Then certain tumors are embryonic tumor that originated in some abnormally developed organ or some organ rests. From that they developed. Then in embryonic tumor, this proliferation of the embryonic cells occurs which have not reached the differentiation stage. So differentiation stage तक नहीं पहुंचा है, उस cell arrest, and then these cell what they do is they proliferate as undifferentiated or partially differentiated stem cells. That is the basis for your embryonal tumor forms. Then some tumor, they have features of normal embryonic or fetal cells in them, which proliferate under growth promoting influence of oncogenes. So these suffer from mutation which make them appear morphologically malignant. So these some histogenesis basic facts you have to remember. Then coming to fifth point, that is in some case what happen, these malignant embryonal cells, they may cease to proliferate, तो वो वहीं रुक जाएगा, and they transform into a non-proliferating mature differentiated cells. So some tumor, they have mature differentiated forms also, like your neonatal neuroblastoma, they may mature and differentiate into benign ganglioneuroma. So shifting of the undifferentiated cells into differentiated cells. Now, tissue in the fetal sacrococcygeal teratoma, they sometimes may mature with age to adult tissue and they have better prognosis when we come to its consequences. Sometimes what happens, the normal somatic cell maturation and the neoplastic development in embryonal tumor, they represent two opposite ends of ontogenesis. So with capability of some such tumor to mature and differentiate to become innocent from their malignant behavior. Now, some points about the benign and tumor-like condition which are seen in this infancy and childhood period. So most of these benign tumor, they are growth of some displaced cells or mass of the tissue. So with the growth of the child, so these cells keep on proliferating, and what happens sometimes these tumor mass can undergo self regression also or spontaneous regression, which is not seen in true benign tumors. Benign tumor में क्या होता है कि एक बार अगर tumor form हुआ है, so that is a proper tumor. It's fact that it's not malignant. It does not have features of malignancy. But जो benign tumors के जो features होते हैं वो रहेंगे. But जो tumor like conditions होती है ना, वो क्या करती हैं, they behave like tumor but they regress spontaneously. इसलिए हम उनको कहते हैं tumor like lesions or malformation. So some points about your tumor like lesions, उसमें आता है hematoma. Hematoma क्या होती है? Focal accumulation of cells that is normally present in that tissue, उसी का, but they're arranged in an abnormal manner. जैसे suppose एक कोई ऑर्गन है ड्यूरिंग इनिशियल डेवलपमेंट स्टेज, जो टिश्यू उसमें होने चाहिए थे वो एडल्ट में रिग्रेस होने चाहिए, बट क्या होता है वो टिश्यू जो इनिशियल ईयर्स में नॉर्मल था, so that may continue to be seen in adult age also. So that is accumulation of that cells which is representative of that organ, but in some abnormal manner, or the arrangement is not normal, though they are present at their normal site, but their arrangement is not normal, appropriate to that specific period, so they do not reproduce normal architecture identical to the adjacent tissue. इसीलिए हम उसको कह रहे हैं ट्यूमर लाइक लीजन है, नॉर्मल भी नहीं है but they are behave like tumors. Then your choristoma, that is heterotopia. This is collection of your normal cells and tissue at aberrant location. That is the difference from your hamartoma. So like you get some pancreatic tissue in wall of small bowel or stomach. Now coming to malignant tumors. Benign tumors we'll discuss. So tumors of infancy and childhood differ from those in adult. Fine. So see, what you have to remember, what are the difference, basic points of difference in malignancy in children, that is you see from adult. This is size. जो बच्चों के ट्यूमर्स होते हैं वो मेनली होते हैं आपके ब्लड से रिलेटेड, हेमाटोपोइटिक सिस्टम से रिलेटेड, न्यूरल टिश्यू, सॉफ्ट टिश्यू. When you compare it to tumors in adult, their common locations are your lung, breast, prostate, colon and skin. The genetic basis में many tumors of infancy they have underlying genetic abnormality. Fine. Then regression. Fetal and neonatal malignancy they have a tendency to regress as uncompared to your adult malignancy. Then fourth point is they have a unique histology. The infancy tumors, they have a unique histology in having a primitive or embryonal appearance rather than pleomorphic anaplastic. जो हम malignancy features पढ़ते हैं ना, cells, high NC ratio, marked pleomorphism, then those features are less seen in your tumors of infancy and childhood. ठीक है. Management, most of the pediatric malignant tumors are curable by your chemotherapy or radiotherapy, but they may develop a second malignancy. So now few general points to remember. In infancy and children under 4 years of age group, your most common malignant tumors are various types of blastomas. Between 5 to 9 years, it is your hematopoietic malignancies like acute lymphoblastic leukemia. In age group of 10 to 14, the soft tissue or the bony sarcomas, they are more prominent tumors. So these are important to remember. Now common pediatric tumors जो होती हैं कौन कौन सी होती हैं? So just to brief about few points about your benign क्या क्या होंगी? Hemangioma, that is most common in infancy, commonly seen as your skin on skin and also known as your port wine stain. They may regress spontaneously. Then hemangioma के बाद आता है lymphangioma. It can be of two types, cystic and cavernous. They are located in skin or deeper tissue and they tend to increase in size after birth. Then third is a sacrococcygeal teratoma. They often accompany other congenital abnormalities, though majority are benign, but 75% are benign. Rest are immature or malignant also. Then fibromatosis. These are usually solitary, जो benign होती है, multifocal अगर होगी, they are locally aggressive. Then tumor-like lesion or benign tumors जिसको कहते हैं, some nevi, like nevocellular nevi, they are very common lesion on skin. Then your liver cell adenoma, most common benign tumor of liver. Rhabdomyoma, these are rare fetal tumor. I'm just briefing out the names of tumor-like lesions and the benign tumor like lymphangioma, cavernous hemangioma, lymphangioma, sacrococcygeal teratoma. So these all are, just you have to remember the different types. Now the important part is small round cell blue cell tumors. So small round blue cell tumors जो होता है, it comprises of a big group. Like you get different long questions also on SRB CTs. That small blue round cell tumors जो होती हैं, एक ग्रुप ऑफ ट्यूमर्स होती हैं चिल्ड्रन में, क्योंकि इनकी जो हिस्टोलॉजिकल मॉर्फोलॉजी होती है वो बहुत सिमिलर होती है. सो these are group of tumors which you see in children. They have histological features of small round cells, so they are grouped together or clubbed together, you can say, under a broad heading. Obviously, they have a high malignant tumors होते हैं, they have high ANSI ratio, and morphology अगर आप histopath पे देखोगे, so they have very identical morphology. So we have to use immunohistochemistry to differentiate the different small round blue cell tumor in children. So these are the list of common examples हैं जो small blue round cell tumors में आते हैं in children. So first is your Ewing sarcoma, or you can say undifferentiated small round cell sarcoma, lymphomas, retinoblastoma, neuroblastoma, Wilms tumor also known as nephroblastoma, hepatoblastoma, medulloblastoma, rhabdomyosarcoma, desmoplastic small round cell tumor, and small cell osteosarcoma. So ये common example है small blue round cell tumor के, which you see in children. So no, उसके बाद भी what are the different common pediatric malignant tumors? So now we'll concise our discussion to these things. Hematopoietic जो होता है system, blood को involve करता है, less than 4, 5 to 9, till 9 year you can see acute leukemia to be the predominant one. Above 10 years, what you see is Hodgkin lymphoma का first hit होता है. Hodgkin's lymphoma has bimodal presentation. First you can see in 10 to 40 also, and second in the 20 to 40 age group also. Then comes the second system, second broad category, that is blastoma. Less than 4 year में आप देखो neuroblastoma, hepatoblastoma, retinoblastoma, nephroblastoma, pleuropulmonary blastoma. Then in age 5 to 9 years, you see neuroblastoma and hepatocellular carcinoma. 10 to 14, hepatocellular carcinoma. Then third category, soft tissue अगर tumor में आते हैं बच्चों में. Less than 4 में you see rhabdomyosarcoma. 5 to 9 you see soft tissue sarcoma. 10 to 14 also you note soft tissue sarcoma in children. Then bony tumors, less than 4 years में नहीं होती उतनी common. ठीक है? In 5 to 9 it is Ewing sarcoma. 10 to 14 years it is osteogenic sarcoma. Then neural tumors, most common in CNS tumor होती हैं less than 4 में. Till 9 years you can expect CNS tumors. Then other less than 4 years में other tumor which you can see is teratoma. 10 to 14 years में you can see thyroid carcinoma. So what is acute leukemia? Leukemia actually it's a very serious medical conditions है जो कि relate करते हैं original diagnosis of your leukemia. Most cases leukemia what you see is दो lineage में we divide it into two lineages. One is myeloid, other is your lymphoid. So they have an uncontrolled growth. Fine. So what acute leukemia they include is acute myeloid leukemia, acute lymphoblastic leukemia. Then the second next category is your retinoblastoma. Retinoblastoma एक rare form of rapidly developing cancer है that develops from your immature cells of retina, that is the light detecting tissue of the eye. Most common primary intraocular cancer in children and almost exclusively found in young children. So high income countries say they survive this cancer, but they may lose their vision or they need to have their eye removed. Almost half of the children with retinoblastoma, they have a hereditary genetic defect which is associated with your retinoblastoma. And sometimes it is caused by your congenital mutation in chromosome 13. Then nephroblastoma, इसको हम कहते हैं Wilms tumor भी. ये you see it in kidney, developing kidney. So it's a malignant embryonal tumor which is originating from your nephrogenic blastema, which imitates the histology of a developing kidney. Primarily, it is seen in children. Now, this Wilms tumor, what is the importance? They have triphasic feature. That is, you can see blastemal, epithelial, and stromal component variable amount में. कभी आपको स्ट्रोमा ज़्यादा दिख सकती है, कभी epithelial component ज़्यादा दिखेगी, कभी blastemal ज़्यादा दिखेगी. So biphasic and monophasic, they are not infrequent. Means you can see. Biphasic means with two components. Monophasic is only one component predominantly you are getting. So the two main treatment approaches होती हैं इसकी. एक होता है International Society of Pediatric Oncology, which uses preoperative chemotherapy. So before any surgical or any other intervention, they give preoperative chemo to the child. Then another is your Children's Oncology Group, which advocates that primary surgery should be done first before giving any chemotherapy. So both followed by, so anyway, either surgery के बाद, सर्जरी कराओ उसके बाद भी the patient has to be given chemo and radio, या सर्जरी के पहले अगर कीमो दे रहे हो, then also after surgery you have to give child proper chemo and radiotherapy. So both approaches, they have their own histological classification and they have their own risk assessment, which is based on their prognostic factors. So overall survival seed is very good in Wilms tumor, 90%. So this tumor, they are actually thought to develop from your persistent metanephric tissue or nephrogenic rest. So they are believed to be due to some genetic alteration of embryological development of your genitourinary tract. So इसमें दो जीन होते हैं, एक होता है WT1, एक होता है WT2. So WT1 gene, which is located at chromosome 11p13, that is implicated in your tumorigenesis. And how the child will present to you? Abdominal mass लेके आता है बच्चा with no associated symptoms. However, in 20 to 30% of cases, what you can see is abdominal pain, hematuria, hypertension, anemia. So most common predisposition syndrome जो होती हैं, there are Wilms tumor जो होता है वो other syndromes के साथ associated होता है. Usually congenital है, genetic abnormalities होती हैं underlying बच्चों को. So high risk वाले जो more than 20% होते हैं, उसमें वैगर सिंड्रोम होता है, विल्म्स ट्यूमर, एनिरीडिया, जेनेटिक एब्नॉर्मलिटीज, इंटेलेक्चुअल डिसेबिलिटी. देन डेनिश ड्रास सिंड्रोम. मॉडरेट रिस्क जो 5 to 20% होती है, उन बच्चों में होता है बैकविथ वाइटमैन सिंड्रोम, सिम्पसन गुलाबी बेमे सिंड्रोम, फ्रेजियर सिंड्रोम. देन लो रिस्क वालों में होता है लेस देन 5%, उसमें होता है ब्लूम सिंड्रोम, डाइसर 1, ला फ्रॉमनी, आइसोलेटेड हेमी हाइपरट्रोफी. So these are some syndromes which is seen in association with your Wilms tumor. So kaisa, how grossly when you note it, the kidney becomes usually large, solitary hai, spherical mass and sharply demarcated hota hai from your renal parenchyma. However, kidney is distorted. 10% it is multinodular. Primarily operated case mein what happens, tumor is grey white or pink grey in color, lobulated, soft and friable. Some tumor may have your prominent cystic appearance. Now in pre-treated case what happens, hemorrhage and necrosis are usually evident. So see, very properly circumscribed है और adjacent renal parenchyma आपको दिख रही है. So this is preserved renal parenchyma. Cut section है ये, book open like a book. Here what you see, this is a, यहाँ मास को हमने प्री कीमो दिया हुआ है, ठीक है. So it is turning a bit more hemorrhagic, blackish discoloration आपको दिख रही है इसमें. माइक्रोस्कोपी में as we said discussed now, कि properly 3 components आप देख सकते हो, blastemal, epithelial और stromal. But biphasic और monophasic भी rare नहीं है. Frequently we can note it. ब्लास्टिमल कंपोनेंट जो होता है वो लीस्ट डिफरेंशिएटेड कंपोनेंट होता है. स्मॉल टू मीडियम साइज्ड अनडिफरेंशिएटेड सेल्स यू विल सी with relatively small regular nuclei and small nucleoli. So they have different patterns in it. So diffuse, serpentine, nodular, basaloid. So which are of no prognostic significance, but yes, you can differentiate the different pattern which you are noting in the blastemal component. Mitotic figures are very frequent. So see, so hazy appearance. It's like a cellular tumor. सबसे पहले impression आता है इस slide को देख के, oof, it is so congested. So small cells जो होते हैं, they are seen in your diffuse sheets. Correct? Then comes your epithelial component. Blastemal था छोटे छोटे small cells. Epithelial component में आता है rosette like structures हो सकते हैं अगर poorly differentiated है. Moderate differentiated में you can see tubules and papillary. Well differentiated you can see glomerular structures, mature tubules. And other component also you can see squamous elements भी दिख सकते हैं आपको, mucinous और glial tissue. See, small tubule जैसे दिख रहे हैं यहाँ पे आपको. So these are small tubular areas, small sheets में आ रहे हैं tubule. So these are your epithelial component. Then you can see some squamous line also. ठीक है, यहाँ पे आप देखो keratinization दिख रही है. Fine. Then stromal component में क्या होती है? Stroma जो background होती है, they can be your hypo or hypercellular undifferentiated area भी हो सकती है, to well differentiated area also you can see. So these cells will have no clear boundaries. So they are oval to spindle shaped nuclei here with bland nucleoli. So they will show you Heterologous elements, that is like your rhabdomyoblast, adipose tissue and cartilage. So see, this is the stromal, pura herringbone pattern mein. Like you can see here, muscles and all this all going here. Then anaplasia क्या होती है? Malignancy like features. Keep cells बहुत haphazard हो रहे हैं, irregular से हो रहे हैं. So that you can see in your 5 to 10% of Wilms tumor के case. And how you notice it? Cells will be enlarged, atypical, tripolar, multipolar mitotic figures, marked nuclear enlargement, hyperchromasia. So all these three features have to be present, may occur in any one of the component. Focal anaplasia आप कहते हो when you have a clearly defined focus within a primary intrarenal tumor. The two different grading हमने देखी थी treatment protocol. तो SIOP में up to 2 foci of up to 15 millimeter in size, that is defined as your focal anaplasia. In the oncology group, children oncology group, up to 4 small foci and size has not been specified for the to call it or label it as focal anaplasia. Diffuse anaplasia किसको हम बोलते हैं? That is non-localized anaplasia. Anaplasia beyond the tumor capsule, anaplastic cells in intrarenal or extrarenal vessels, renal sinuses, extra capsular sites, metastatic deposits, or anaplasia in a biopsy. So this was all about your Wilms tumor. Now we are moving to other type of your small round cell tumor, that is your Ewing sarcoma. Small round cell sarcoma होता है, इसमें CD99 IHC is very important. That shows your diffuse membranous expression. And here what you see is gene fusion, which is involving your FET family of genes, usually EWSR1, and members of your ETS family of transcription factor. This is the second most common malignant bone tumor in children or young adult after osteosarcoma. Male with slightly predominance is noted with 1.5 is to 1% of incidence. Peak incidence you see in second decade of life. Nearly 80% of Ewing sarcoma patients, they are less than 20 years. Uncommon in patient younger than 5 and older than 30 years. But still, there's nothing called absolute no-no. You can see Ewing sarcoma in less than 5 and more than 30 also. Where you see it, Ewing sarcoma, Diphysial or metaphysial होता है ये. Diaphysis region of your long bones. Lower extremity is more common than upper extremity. Pelvic bones and ribs are also affected. Bones are usually more affected than your soft tissue. Soft tissue Ewings भी होता है. 12% are extraskeletal. How the patient present to you? Patient will complain of your localized pain and swelling, painful enlarging mass, associated pathological fractures sometimes can be seen. Patient can have non-specific, the constitutional symptoms जो होते हैं, fever, weight loss, anemia, leukocytosis, and your increased ESR. That is very non-specific. Gross, how you see it? The tumor होगा bony tumor, grey tan mass with infiltrative border होता है. The intramedullary mass with soft tissue involvement. You can see areas of hemorrhage and necrosis, and you can assess the chemotherapy induced necrosis. More than 90% good, like with mapping. So here see, bone को देखो, ये था bone वाला, तो metaphysis को involve किया, पूरा growth is involved here. So classical जो Ewing sarcoma होता है ना, उसके microscopic features when you're asked to describe, so what you will see is these cells of Ewing sarcoma are uniform small round cells. They are tumor cells 1 to 2 size times more than that of lymphocyte size. They have a round nuclei, fine stipple chromatin, inconspicuous nucleoli, scan clear to eosinophilic cytoplasm with indistinct cytoplasmic membranes, islands which are separated by your dense fibrous tissue and with subset with neuroectodermal differentiation, where you can see your Homer right pseudo rosette. So these are microscopic features of your classical Ewing sarcoma. So see, small cells in sheets. CD99 पॉजिटिव होता है. वैसे स्मॉल सेल्स को देख के इट इज वेरी डिफिकल्ट टू से कि वो rhabdomyosarcoma है, न्यूरोब्लास्टोमा है या Ewing sarcoma है. Correct? So you need to have your IHC protocol proper. Then coming to your Hodgkin's lymphoma, it's a type of lymphoma, double hit lymphoma होता है ये, double age group को involve करने वाला. So this is a cancer which originates from a specific type of white blood cells, that is your lymphocytes, multinucleated Reed-Sternberg cells present in your patient's lymph node. Okay? This condition was actually named by English physician Thomas Hodgkin. इन्होंने first describe किया था इस entity को in 1832 with due respect to him. What he noted was the patient initially they had non-specific symptoms like fever, night sweats, weight loss, often non-painful, enlarged lymph nodes which are seen in your neck, underarms, or in the groin region. The patient may feel tired or be itchy. So two major type of Hodgkin's lymphoma are your classical Hodgkin's and your nodular lymphocytic predominant Hodgkin's lymphoma. So about half of the case of Hodgkin, they are associated with your Epstein-Barr virus, and they are seen generally in the classic Hodgkin lymphoma. Other risk factor which are associated with this is family condition, family history, or patient having HIV or AIDS. So diagnosis is how you confirm it, confirming the presence of cancer and identifying your Reed-Sternberg cells in lymph node biopsy. The virus associated जो होंगी, they can be classified as Epstein-Barr virus associated lymphoproliferative disease. Now this Hodgkin's lymphoma may be treated with your chemotherapy, radiation therapy or stem cell therapy. The choice of treatment will depend on how advanced the cancer has become, whether it has some favorable features or not. और अगर disease अगर हम जल्दी detect कर सकते हैं तो cure is often possible. US, what happens, data which is retrieved is that 88% of people diagnosed with Hodgkin's lymphoma, they survive for 5 years or longer. So that's why the 5-year survival rate is very important. Initial lectures also I have told you what is the significance of this 5-year survival. So for those under age 20, the rate of survival are 90%. But see, when you give radiation or some other chemotherapy, and that too we are giving at a very young age, so they have increased risk of other cancer also, some other heart disease or lung disease over subsequent decades. For that, you have to be cautious. So this is a Reed-Sternberg cells. You have a binuclear cells, glass-like spectacle appearance wale cells होते हैं. Single cells and large cells. Here you can see. So these were the some basic tumors which I wanted to highlight about it. Ki we should know in infancy and child. So acute leukemia में acute lymphoblastic leukemia देखते हो आप. Blastoma I discussed with you, retinoblastoma, nephroblastoma, which are commoner as compared to other blastomas. Then rhabdomyosarcoma, Ewing sarcoma common होता है बच्चों में. So these are few tumors, and gradually in my subsequent lectures I'll deal like Hodgkin's lymphoma if I describe. So that will take another lecture. So I'll do it gradually over the time. So thank you so much for your patient hearing. So kindly like, subscribe, and share to my YouTube. Share my YouTube channel. Thanks again.